Good morning or good afternoon, depending on where you are in this country or whatever time zone you are around the world. I'm David Nace, Chief Medical Officer at Innovaccer. And today's presentation, Risky Business, not the movie, but rather, how do we think about the concept of risk adjustment, and how do we leverage a digital framework to really accelerate your risk adjustment strategy? So welcome, everybody. And without any ado, let's get into it. So what we're going to cover today in today's conversation is talk about where are we at today? What's been the risk adjustment journey for payers to date? What are some of the challenges and opportunities that we're seeing, and what's the path forward to address these challenges? And how do we think about enabling the right workflow between payers, providers, in the service of the member? And then how do we think about the technology innovations that have occurred that might help to enable this? So let me introduce you to the panel we have here today. We have some very esteemed colleagues who have some great insights on this. Charlie Booten, who's manager of risk adjustment at Blue Cross Blue Shield of Vermont. Charlie, welcome.
Thank you very much. Very excited to be here and participate with such a great panel. So looking forward to lively discussions. Thank you, everyone.
Absolutely. And Mark Gantz, who spent a long time as CEO of Cambia Health Solutions and is on our strategic advisory board here at Innovaccer. Mark, welcome.
Thank you very much. It's good to be here.
And then lastly, Nate Jacoby, who is the actuarial health director at PwC in his consulting practices and works with lots of payers around the country around this issue. Nate, you're going to have some good insights today, I'm sure. Welcome.
Absolutely. Thanks for having me today.
We also have two guests who are joining us. Sandy Bellomo, Vice President for Service Operations at Horizon Blue Cross Blue Shield of New Jersey. Sandy, we may call on you for questions. And David Rich, Assistant Vice President for Member and Provider Experience at Molina Healthcare. The two of you are on and are joining us. Great to have you. Welcome. So without any further ado, let's talk about this issue of where did we start? What has been the road traveled today? And what's going on in the market today? So with that, and we were just having a little brief discussion prior to going live for the webinar, there's been a lot of news about this issue. We see CMS taking a stance. So we've got a lot of news hitting the New York Times. MedPAC has a position on this, et cetera. Nate, let's start with you. What's your view of what's going on and where are we at today?
Absolutely. And to say it's been a short discussion is an understatement. We've had multiple discussions on this topic as it's kind of been in the news, in and out, and kind of ongoing. And I think it really stems from what is risk adjustment and what's the point of risk adjustment. It was invented as a way to kind of normalize the population so that insurers weren't necessarily picking off the healthy members and getting that good risk. And over time, it's become a strategic game of how do we code and how do we improve kind of the revenue. And it's taken the member out of the central part of what risk adjustment truly means. And the government is kind of pushing back on that. You see from some of these headlines, kind of the cash monster and how this has turned into a revenue gaming and scheming position. Now, for some it has, and others it hasn't. And the idea is, how do we identify truly good documentation and truly good risk adjustment, as opposed to just coding things to get the revenue and not actually taking account for that? We see the government kind of pushing on this because it does have far and long sweeping implications on revenue, especially in the Medicare space, where dollars are kind of accruing in a much higher tick when you do get those larger and larger scores. So it's really going back to the fundamental principle of how do we code accurately and ensure that those codes are flowing through into care plans that the member is actually being accounted for. And Mark, I don't know if you have other thoughts, but I think this goes back to kind of member centric, right?
Right. And I think there's a political angle to this, which is there are still, there's a significant, faction, you could say, that doesn't really like the fact that Medicare Advantage is becoming a larger and larger slice of the Medicare population, and would like to drive everything back toward Medicare fee for service. So this becomes a very easy target to go after and say health plans are, making way too much money on this and, being running fast and loose with the truth in terms of just maximizing revenue. And I think that's something that, I think is real. And for health plans who believe in Medicare Advantage, and I would say most do, and I believe that a lot of the health care providers do as well, they're seeing the benefits of that program, not just financially, but in terms of the flexibility it gives them to treat patients really in a more holistic way and offer better benefits to them. There's a reason to take this seriously and not just take it as a legal threat, but really more of a threat to the future of the Medicare Advantage program as a whole. And frankly, if this isn't addressed in a creative and serious manner, then the program is going to be threatened. And so I think that's sort of the call to action, is that this is not just a legal threat. It is a larger threat to what is essentially a better way of providing Medicare to many, many people, and at least a good alternative for a part of the population of this country. And it's worth fighting to do it right. That's one thing I would say. The other thing I would just say is that, it is a truism, and I certainly saw this just through my long tenure in the business, is that once the feds, especially the Department of Justice, get their, the bit in their mouth, they run. And this isn't going to just go away soon. There's a whole skill set, if you will, of people now that are going after these concerns around how things are coded or recoded, et cetera. And the inertia, the momentum is that more of this is going to happen. So that should be also create a sense of urgency about how to do this better and do it right.
And I think we have to be clear too, it's not all health plans and it's not all providers, right? This goes into the average, and it goes into kind of the actual value of it, which is some are pushing on it a lot more aggressively than others. And the headlines that we see here are potentially a scare tactic to say we're not going to catch everybody, but kind of everybody needs to go back into the position of accurately documenting. And there's plenty of customers that come to us and say, the coding intensity factor is way too high. There's no way we can ever get to that. And that's kind of the point, is it's grown and it's grown and it's grown because of this kind of impact, that those that are doing well and those that are doing right by what risk adjustment truly is are effectively being penalized because of that implication. And to Mark, your point, how do we go back to doing this correctly is the right stance, because going back to doing it correctly actually means going back to getting the right reimbursement for the remainder of plans that are doing this correctly, and being able to provide the right supplemental benefits and the right care offerings that those plans should be able to offer.
That's right.
And this is Charlie. And what I've seen is that, risk adjustment's been around since the late 1990s, and it's been morphed to where we are now. It started with PIP TCGs on an inpatient side only. And then it started moving, mostly with Medicare and then into, Medicaid. Nice thing about Medicare is it's consistent across the states and the territories participating in the program. Medicaid is different, almost by state in many different ways. And now ACA is here. And there's a lot of audits going on, and things have changed from year to year as to what's included in the models, what the weights are. At one time, early on, Medicare in ICD-9, you could use just a 250 with nothing after the decimal place to quantify for diabetes, and that's not the case anymore. And they changed that shortly thereafter. So there's a lot of changes, and as was just mentioned about the coding intensity factor, trying to ratchet down those costs. And CMS themselves are being audited by the OIG, which gets where they come to the plans. And as you see some of these slides, and you can see in the news and lots of other times, the large fines that plans have been hit with because of the extrapolation methodology and everything else.
Right.
So there's a lot of money on both sides of the equation. And because of that, even, OIG is getting involved in doing the audits of CMS by auditing plans, et cetera. So
That's
it's
an
something
interesting.
we've got to make sure we stay compliant with. Revenue and compliance are hand in glove.
Mark, hold that thought, because I loved what you said about it's also a political issue. And any of those who are policy wonks like myself, read Health Affairs, that dialogue that Rick Gilfillan and Don Berwick started not too long ago is really getting a lot of traction. And I have to admit, I have asked many of my friends, having just turned 65 and being Medicare eligible, what are they doing? And half of them say, I don't want to do Medicare Advantage, right, for a variety of reasons. And others say, absolutely, it's the best thing for me. So we got to really get this right if we're going to move forward. Mark, I know you were going to about ready to make a comment. It's a complicated issue. It's all yours. Go ahead.
Well, I would say I agree. It is complicated and not helped by the fact that the guidance coming out of HHS has changed. And instead of necessarily doing it by rulemaking, which then is more of a dialogue process with the players in the system, both providers and payers. They did it through, quote, guidance, which really was a change in the rules under the guise of saying, well, no, this is the way we always wanted you to do it. A neat trick, and I think it's created a lot of confusion. But I guess if you get away from, that and you really think about what is, what are I think Nate picked on and correctly identified what risk adjustment was really supposed to be about. So when we think about tomorrow's opportunities, it's about refocusing on, it's about the member, stupid. And it's become, and it happens so often in healthcare, where it becomes all about, it plays into the traditionally adversarial relationship that health plans and providers have had. Not a lot of trust in a lot of those relationships, very transactional. And this became kind of just another part of that transactional relationship. Coming out of COVID, I think the financial pressures that particularly providers are feeling that are very complicated, that's putting even more focus and pressure on the transactional part of the relationship at the exact time where members, especially Medicare members, are crying out for, kind of keep your eye on me, help me and serve me better, and collaborate more to serve me better. And lots of lip service about that, but we have a long way to go. And I personally think that when it comes to risk adjustment and doing it right and having it be sustainable, you cannot do it without payer-provider collaboration. You cannot do it without an appropriate level of member engagement. And what I guess I mean by that is keeping the focus and the reason for doing everything we do on the member, not dishing off and saying, well, the member needs to change to serve us better and make it easier for us to do our job. It's being more curious about the actual persons that are going through a disease, an illness, whether it be chronic or acute, and keeping the focus on how do we serve them best. And we talked about the increased scrutiny. And then if you really believe in a collaborative approach in serving the member, then one of the critical path items to address is better integration of clinical data and investing there. And that, while there's been, again, a lot of lip service, it's not happening yet in a deep way. But there is opportunity because there are inventors and companies that are working really hard at figuring out how to facilitate integration across multiple platforms so that you can get to a single source of truth. And, you know, the opportunity is to embrace that, not make technology the answer, but in the service of real collaboration that is member focused, using the new tools and platforms that are out there to create that common integrated platform across the players in healthcare.
You talk about collaboration, and you talk about some of those things where, yeah, the member is really thought of in risk adjustment as we got to get them into a visit just so we can get things documented, which then slowly transitioned to, well, we can't get them in for a visit. Let's send vendors to their home and do in-home assessments. And where does that data sit at most plans? It sits in a supplemental file. It's not fully integrated, right? And if it's not fully integrated as the payer, how does it go back to the provider? How do the providers get that information then to be able to treat and cure and do the right activities? And to your point, it's not happening. We don't have that integration of data. We usually see that integration of data in the submission of codes to CMS, but we don't see it kind of going back then to the member. And that's really where I think you're going, is where it needs to go. How do we integrate that? How do we get that in the right platform?
So Charlie, you're in the middle of this every day. And again, there's a lot of levers we're talking about here: integrating data, thinking about better service for the member, not losing sight of that. What's your day-to-day view in terms of how you're thinking about these things?
The way we've approached it is that we have essentially three constituents. One is our company, second is the member, and the third is the providers. And so in trying to coordinate all of those, and when I use the term provider, I'm speaking about not just the practitioner or clinician, but also their team members, their staffs, their coders, because initially when we were first starting this, we were only doing education to the provider community and doing some training and education at association levels and things. Then realized they're not the ones who are doing the codes, unless they're very small operations. And then when we're trying to work to support them, we provide reports to the provider offices and work with their population health person or staff member to really know which of their members have multiple chronic conditions and haven't been seen in a period of time. The reason being is we really are trying to help the providers. They're all busy. And if we don't give them an opportunity to know which members are more frail in their practice to try to get them in, those members may not be able to follow through on the care plan as things are changing for themselves. And then when we get the data, we do a lot to share that data internally, because a lot of times people do a lot of risk adjustment via the claims information that they gather and not through the review of medical record information and what they submit now through the Edge server, et cetera. The concern there is that claims are submitted for a provider just to be paid, not to give us a clinical accurate picture of their patient. And so what we've tried to do is, as we do what I affectionately call the brute force chart reviews, we do these blind coding reviews of several thousand medical records every year, then we share the results of that with our clinical team, so that the case managers can better identify which members have a multitude of chronic conditions that are not gathered through just what's on the claims. And hoping that we can, through the support of other departments, because risk adjustment's not an island unto itself, that case management, population health, disease management can reach out to some of those more frail individuals who have specific issues and reach out and offer so many of the additional services that many plans across the country have available to both providers and members. So that's the approach that we've tried to take, is to share that information. We did 7,600 medical record reviews last year and found over 16,000 chronic conditions for those members that were not in claims. And so there's a very large amount of information that doctors have documented in the medical record, but does not come in on a claim. And so making sure we understand that, sharing it with the right people internally who can utilize that information makes a big difference.
Mhm.
It really does sound like, trying to figure out, as you've described, addressing these silos, being a catalyst for, effective payer-provider collaboration and really trying to figure out not losing the provider's sight on the member, because that's why the providers are seeing members. That's why you serve members as an insurance company. Nate, are these the sort of strategies you're seeing around the country?
Yeah, absolutely. And I want to hit on the point that you were just chatting about, Charlie, which is medical claims were always intended to just get paid, right? The whole point of the claim to submit to the insurer was for payment. It wasn't for full and accurate documentation. That's what the medical chart is. So we kind of set a platform of risk adjustment and other things, stars, HEDIS, on top of claims, which really was not the right foundational building block. And going back to that and making that better through technology and better information transfer is really what's going to help the overall end to end here. So as we become that catalyst to shift to VBC, it's how do we transfer data not only from the provider to the insurer, but from the provider to all of the care platform? How do we get that to the inpatient facility? How do we get that to the specialist that's treating them for specific diseases, your cancer doc? And how do we integrate that information in a more collaborative environment as opposed to the insurer is the center of the data universe, and the member really has the center of their own history and their data that they can transfer with every payer provider that they see.
I think that's well said, both of you, and because again, you both speak to. I always think that the great place for integration, the great place for collaboration between payers and providers is at the patient level and their family level. But yet I'm always struck. I remember many times sitting down with colleagues from the hospital community, and when we talk about doing something innovative and collaborative, the first principle, we'd always start with principles, and the first principle that I would always put on the table is it's about the patient, and that's our point of collaboration. And I just remember how that was like, oh yeah, of course, and then move on, and that's part of the problem. And Charlie, you spoke to it, and I thought it was very astute, which even within a health plan, sometimes that sense of collaboration, even across departments, where the information, you want that information flow that you learn during a risk adjustment process to be able to flow to the case management area and others, so that it's again about creating a better experience for individuals and their families that are trying to care for them. And so this collaboration thing, I guess you could say, it is payer provider that's critical, but the point of union has to be at a very personal way toward individuals that we're all entrusted to serve. One of the things that I think is actually a barrier, and Charlie, I'd be interested in your perspective on this, but I was never particularly fond of or comfortable with the idea of hiring, these independent companies to go in and, like guided missiles to go in and do the records reviews. There was, and what made me uncomfortable at it was why they thought they were in business and what they thought their mission was. And I was keenly aware that what they did was us. So we couldn't pass the buck, if something came up later and say, well, it was them. One, that's not, it's not ethical, when you think about our duties to our patients. It's just also not an excuse when people are auditing you. And so I sometimes think that while the health plans have been well-intentioned in trying to use companies that are focused on that, I'm not sure how well health plans have done at vetting them, holding them accountable, making sure that they're acting with the same kind of ethical standards that you as a health plan would expect if you were doing the work yourself. And I do think that if you're a provider, it feels like, somebody is being sent in to mine your records, and it feels very distancing as opposed to collaborative. I'm curious, in your real world work today, how you think through that, and how, because I think health plans have to do better in that, in how that whole relationship works with third-party vendors.
A strong point. And on the third-party vendors, we need them because we have a small department. Vermont's a rural community, and we're not the only rural state in this country, but it's difficult to be able to go and visit all of the providers. We have a lot of remote EMR access that we're able to utilize to look at members' records. But the big point that you mentioned is when we're requesting records for RADV audits, whether it's in Medicare or ACA populations or our supplemental CHOP funds or HEDIS work, we are careful to mention a couple of things. The first thing, it's a partnership with the providers. Second, if it's an audit of us when it's a RADV, not of the provider. There's a different department that will audit and providers if they're not doing the right things, whether it's called fraud, waste, and abuse, or payment integrity, or something else. And then we spend a lot of time, because we can't do all the CHOPs. We do 7,000 to 8,000 medical record reviews. We do them on a blind coding basis. We then, my team laughs because Charlie says, we need to inspect what we expect. So each of our vendors, even our IBA auditor in the ACA world, we audit the work that they've done so that we can be sure that they're doing the right things. And I do have a full-time coder on staff, and one of her tasks is risk mitigation. She's looking to see what are the problems that are out there in what's been published from OIG, CMS, RADV results, so that we can see how can we do things better to ensure that we're not at the wrong side of something. And we very often, the reason we do the blind coding is so that we can delete any codes that would not stand scrutiny for documentation if they were selected for an audit. So in working with vendors, our view is they work for us. And we try to have a strong partnership arrangement with them as possible, but know that they are being overseen by us because we do audit a large portion of what their records are and things of that nature. We do both a random audit and skewed audits of our coding vendors. The main reason for that is random in case we can catch something, but every once in a while it's a skewed audit because we find there's a problem. A couple of years ago, whether it was telehealth. Well, what exactly is it that you're coding and what are the rules for that? And we looked at more of those codes. We do data mine for things that we want to make sure are not being submitted incorrectly. Active heart attack CVAs or MIs in an outpatient setting, something we look for. And then any errors that we do find, we try to classify them as to whether they are at a specialty level, if they are at a practice level, or it's a specific HCC that we as an entity in our network are struggling with. And then we design training programs around that to educate our provider and coder community to be able to make that work. Does that help answer questions? Or did I generate more questions?
No, I think it does. Nate, I'd be curious, like when you're asked as a consultant, to look at a program or provide insight and wisdom, does what Charlie said resonate? And are there other sort of priorities that you hear from plans around this?
Yeah, it certainly resonates. I guess back to the heart of your question, though, which is, what is the morality of kind of those vendors, or how are they helping progress the member-centric view? And I think what we have to do, just overall in the industry is better align the incentive and the reward. Back to your point too, is doesn't matter what the vendors are doing, it falls back on the payer at the end of the day to make sure what is being coded and what is being sent for documentation is accurately represented. So the risk doesn't then lie back with the vendor, lie back with the provider, but the reward does, in the sense of how are they being paid for their services. So part of what we're talking about today is collaboration between them, but it's also how do we better align kind of the incentives and the rewards that go along with the work that they're doing. And I think that falls into what we see a little bit is, when we're looking at the ROI of the vendor, what are they doing not only on the risk adjustment side, but then how are they kind of integrating that data and integrating that within the broader organization of how are we doing care management and how are we looking at the true impacts overall on our overall costs, not only from our administrative side of the fees that we're paying them, but in the reduction of cost and the better management of care.
Let me ask another question then, because you raised an interesting point of both of you is, when it comes to, one aspect of being able to allow real provider payer collaboration to occur in risk adjustment, and frankly, in the broader realm, but just let's keep it at risk adjustment. It would not be an unreasonable statement for a healthcare provider to say, okay, if you want to employ a digital collaborative tool that will help this be more smooth, less of a burden to me as a provider, et cetera, then you as the health plan is you get the most benefit from this. You should pay for it. Why should I have to share in the cost or of the building of it? I'm curious if both of your points of view is, do you think it is the health plan's primary responsibility around coming up with a platform that can be that single source of truth between providers and payers related to the patients that we serve together? Is it the responsibility, and our health plans need to do a better or more focus in investing in such integrating platforms, or is it both responsibility?
Yeah, I think it's a white space where there is opportunity today, and it could be on the provider side, it could be on the payer side, but I think there's an opportunity for a new vendor, a new offering here, where they are able to collect data and then share that. As an example, United's data is going to stay with United, Humana's is going to stay with Humana, but if that member transfers from one plan to the other, effectively the new plan has to kind of start from scratch. And there's an opportunity to keep that member-centric view with some vendor, some third party. So when they do find a better opportunity or a better health plan for them, that they don't have to go in net new and they can kind of hit the ground running. I think there's an opportunity then to align the incentives to the rewards. To your point, this is a big burden on providers. You saw it with ACA, with all the new reporting requirements and the big burden they had for documentation that went along with that. We see it now with the reporting of costs that are coming through. And what does it do for the provider, but kind of create more administrative burden and take them away from being able to kind of collectively care for the member? So yes, there's absolutely a better aligning of incentive, and the payers can certainly help with that burden. There can also be innovation there where there's a vendor or a third party that really comes in and becomes that member-centric view and can help coordinate across payers and providers.
Mm-hmm. Charlie, do you have a point of view on that from?
Anybody who knows me, everybody's got a right to my opinion. I do see that there is a burden on both sides. And if you have very small practices, it becomes very difficult for them to fully hold that whole burden. Heck, even some of the smallest providers or practitioners who have been in business for a long time and don't see themselves sticking around more than 5 years, whatever it is, may not even have EMR systems. They're still working from paper. Surprise, surprise. So it's very difficult there. And I think this is where the plan has to work internally to decide any of these additional revenues. Unfortunately, we're working with a nonprofit organization. The Blues a nonprofit here in Vermont. So a lot of what we capture goes back to members, either lower premiums, more benefits, a combination of the two. But there's also the opportunity to share some of that in maybe new technologies and working with providers. The health insurance exchanges have a lot of information where in various states, those exchanges are trying to create a spot for all of a member's medical information for those providers that participate in the health insurance exchanges, go into one repository and then be able to utilize that. So we're really exploring more to work with the health insurance exchanges that have been put in place where, for us, all 14 hospitals in the state, many of the largest provider groups, et cetera, are all participating there. So if I'm looking for Charlie's medical record, I can go there and see the 2 or 3 different places that Charlie may have participated in different locations for whatever his care might be. So that's a help. But then there are other technologies individual. And whether it's through, if you want to call the health insurance exchange a vendor or not, but social determinants of health is another advantage for us to be able to get an insight to what members are potentially having to struggle with and whether or not there's an opportunity. We're in a rural state, so people who have transportation issues, very big concern, more so than even some of the financial burdens and things of that nature. We don't know who has no vehicle, who doesn't have a registered vehicle or anything of that nature. So those things can be helpful as we move along in trying to understand and put all these various component pieces together and that collaboration with the provider and their office staffs to understand who needs to come in and why. But to the point, should health plans be helping? I think when they can. If plans are still struggling financially, some plans, then it's not going to be feasible for them to do that initially. Same thing on the provider sides. There are a lot of providers who may be going through various reorgs and things of that nature because of financial constraints. And so it's a financial issue that has to be looked at on both sides. The goal is there, but so are the cost. And, you know, who has the pocket to be able to support that cost? I think it's noble that we try to get that in play, but we've got to make sure we're all working together. So I think there are alternatives. And the nice thing about Medicare gives us an indication before a member is even our member. A week or so before, we get the MOR report that says, hey, here are all the new members to your plan. And oh, by the way, Charlie's one sick pup. He's got a dozen different chronic conditions. My hope is that someone in case management is picking up the phone and saying, hey, Charlie, welcome aboard and let's help you out. When's the last time you saw your PCP? Who's your selected PCP? There are ways for us to do things. Now, that's not necessarily technology per se, but I think there's a combination of that human touch as well as technology. And we have to employ all the tools collaboratively. And, you know, to your point earlier about breaking down silos, Dr. Slayton taught me a term a long time ago, de-silification. I don't know if it's a real term, but I understood what he was getting at. And I think internally we have to do that in lieu of being able to always put in some technologies.
You know, this has been a great discussion and, you know, we've really raised a lot of questions for our audience to consider. You know, you've all given lots of examples about choice of vendor, strategies, keeping the focus on the member, trying to think about what is the path forward. Really want to both address these issues about being under the regulatory microscope, and then also thinking about how do we accelerate your engagement of both providers and members, because you want to stay involved with them and you want to stay engaged and collaborate. That said, Mark, you had a great point. Whose responsibility is it? So as an insurer, as a payer, how do you think about two things that got brought up? How do you think about technology? How do you pick the right technology or sets of technology? And then lastly, because it is all about the data, how do you think about getting the right workflow to really ensure that collaboration? We talked a lot about office staff. We talked about the physician, and then again, not losing focus on the member, talking about different strategies about lots of different people auditing each other. So how do we think about technology and workflow? Let's take these a little bit separate. Let's first start about technology. Mark, you had some initial thoughts about that. What are your thoughts about the responsibility of a payer and thinking about an investment for technology?
Well, I mean, I actually think that, I think payers have been investing in technology. Maybe I'll start from this perspective. I've often thought that if my college roommate or best friend happened to become the president of the United States, or if, God forbid, I became president of the United States, I would use the bully pulpit, and I'd bring the health plan leaders around the table at the White House, and I would say, enough of this siloed investment that is quasi-competitive around technology. Work, you all have a responsibility to the American people to have them, present a more integrated, patient-focused approach. And I'm going to give you, 18 months to design a solution that you all subscribe to, and demonstrate to me that you're serious about the investment. And if you do that, then we'll be here to help provide our part, because we have a dog in this fight, an awfully big dog in this fight, through the Medicare and Medicaid programs, to provide you resources to build that common platform that's patient focused. But if you don't, then we're going to do it for you, and you're not going to probably like the result. That you're not going to like the ride. I believe rather than doing it through legislation or, regulation, there needs to be leadership with clout that gets people around the table to do it and bumps it up the priority list where there's a reason that if I don't do it, And I've seen, I was the leader of AHIP for 3 years, as chairman of the board, and I saw that health plans can do that. They're capable of working together, but often there needs to be you need that catalyzing authority, if you will, to cause that to occur. We all know it needs to happen. It's just that we all have other fires in front of us that seem like bigger priorities that are important to our own health, financial health this year. But that's my dream, is that we would have that kind of leadership that would use their bully pulpit to drive people to do what they know is the right thing, which is we need a common platform. I mean, banks did it twice. They did it with the Visa technology and then with the ATM technology. And I'm not trying to oversimplify this and say that it's as easy in healthcare as it was in banks. That's not the point. There's a million excuses why it's more difficult. That doesn't mean it still doesn't need to happen, and that there's an overriding reason for it to happen. And if that happened, then I think we would be, we have gone a long way, and then we would have a lot more moral authority to ask hospitals to do the same amongst themselves or meet us halfway. But right now, we're asking hospitals to do it Cambia's way, or do it Blue Cross Blue Shield of Vermont's way, or Elevance's way, or, and that's, sometimes I don't have a lot of sympathy toward our friends in the hospital industry, but I do on this one, and specifically with doctors and clinics that don't have a lot of the resources, being asked to do things 10 different ways because they have 10 different payers is not the right path. So you asked the question right here, how do you enable the right technology? You have to get people around the table to determine the right technology and invest together to create it.
Well, Mark, you may have lost your opportunity to throw your hat in the ring for president because this is the season and you would have had to do a little bit more preparation. But you may have an opportunity if you've done that. You may not have disclosed that. But
I'm
Charlie,
just hoping one of my friends somehow someday, it happens. But I mean, honestly, I just think that something like that, there has to be a forcing function.
great
get
points. And I think one of the things you're talking about is forcing people to really step up and provide leadership. So that's a great point. Charlie, by point of disclosure, we've worked here in our organization with yours, talking about technology. You want to talk a little bit about how you think about technology to address this very important issue of addressing proper coding, risk adjustment, and collaboration?
Well, we are using your technology, specifically the EndNote, where it is giving a provider a pop-up screen, and I apologize if I'm not doing the best sales explanation of this, but the idea is that as a provider comes in, I go see Dr. Booten, and Doctor looks at me and says, hey, Charlie, I've got to assess these conditions because the information is there to help in that regard. I think the biggest piece for me is making sure we understand what the goal is that the technology is supposed to solve. And if we don't agree on the goal, then we're not going to be able to settle, or someone's not going to be happy with whatever the technology is. So
Right.
To Mark's point of getting the people together to talk, I think that conversation, that leadership has to start potentially with what is the goal we're trying to achieve. And I think that really makes a big difference in revolving everything around the patient, the member. And it's often, a lot of times when you're talking a health plan, we only talk about the member. We talk about a provider. We don't see as a health plan that member is that provider's patient. And I think that makes a difference. So we've got to learn to use the language of the people we're working with so that we have better understanding and communication. So just a simple thing such as, is it a member? Is it a patient? Who are we talking about can make a difference sometimes in being able to have that conversation and that dialogue that Mark was, eloquent about mentioning needs to happen.
Nate, I'm really curious about your perspective on what Charlie just said, because, it's how do you think when you work with plans around the country about choosing the right goals for why you're picking a technology? It's obviously you can't do big bang, and I think, Mark won't be president this round, but as far as I know, but how do you think, what are you hearing from are you seeing the kind of leadership around choices of technology? What are the goals they're picking? How do you think about this? And then more importantly, I think, because Charlie mentioned it about, is it point of care? Is it engaging the physician? How do you do the right technology to enable the right workflow?
Yeah, it's a great transition slide. I'll put my actuarial hat on. When I think about technology, we usually think about technology in terms of mining data and analyzing data. And that's where I kind of see a lot of clients going is, how do we maximize the amount of data that we have, being able to push that through different algorithms or different technology to get to the right answer? And I think where we as an industry have to go is, the right answer isn't necessarily the analysis, but it's how do we go back again to servicing the member and getting the right workflow done. As we take the premiums from the member, what we're doing is agreeing that we are also going to service every member as every other member that we get. And it's not necessarily how do we queue up all the members in a prioritized list. It's how do we ensure that we can actually hit and talk to every one of those members that has a condition that we need to bill, not the ones that have the most conditions or the ones that maximize our revenue, albeit that is the way that the workflows kind of get prioritized now. But how do we actually hit and work with every one of them? And I think that's where the technology has to go is, how do we maximize and get that enabled feature to be able to see all those members, as opposed to the analysis paralysis of, all right, is this the right list or is that the right list? Frankly, it doesn't matter. What we should be doing is kind of focusing again on that workflow.
Charlie, does that fit with the way you've been thinking about it as you've made advances adopting technology to engage the provider?
Yes, I think right in line with what Nate was, talking about. It's starts with the goals, and it's those conversations, and it's, trying to make sure we know who we're trying to support. And the big key of this is both the members and the providers. And the member is centric to everything we're doing, but we can't do it just on the backs of a provider or their office staff or their facility, if we're talking hospitals, because they have their own challenges, as Mark had mentioned earlier. So it's important that we understand how we can support each other in this piece to take care of the patient.
Well, Mark, I know you're really passionate about how we bring all this together, and thinking about this view, I think this is a nice place to sort of summarize the discussion we've having. It's really about multiple parties working together to achieve a number of goals. Mark, does this seem to fit with sort of your perspective of kind of how we're thinking of bringing it all together and the way plan should think about this?
Well, sadly, I think this slide as it is right, that we see right here, is probably not quite the way it ought to be, which is so often I hear both in conversations with providers and payers, it's if we could only get the member to do blah, 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 as if the member is the problem as opposed to who we're here all here to serve. And then it's often used as an excuse for failure to actually do better. It's like, if the member needs to do better, first. So I would just, and I think we talked about this before, and if we move, the member moves over to the being on the right here in the middle of this flow, because there we go, magic. Because that is, it's really the payers and providers and those that are providing goods or services in healthcare. You could put pharma in here as well on the left. They all need to work more effectively in an integrated fashion to create a better experience for the member. I mean, we want that member to have a smile on her face, not a frown. All too often it's a frown. And I keep getting reminded of that, even just in my own family, and the stories that I hear from brothers and sisters and others, and just my memories of even my parents' final journeys in healthcare. How often lost they felt, how often ignored they felt by those in healthcare who seemed much more interested in the daily battle between and among themselves, as opposed to keeping the focus on the needs of who we're all here to serve. So it may sound Pollyannish or something to some, that the member has to be the center of this. But I actually think it's not Pollyannish, it's essential. And I actually think, again, that the journey that individuals and families go through is the great unifier for all of us. Because I think we all wake up in the morning and we whether it's recalling our own family journeys or our own personal healthcare journeys, we want it to work better for individuals. And that's what should be the thing that causes us to rethink our investments and our approaches. And in the area of risk adjustment, to do better, since the whole program was started, as Nate so eloquently pointed out, was started to ensure that members had the best possible health experience.
If we think about this, going back to kind of the cost and that first page about why the government's cracking down, a lot of places are cracking down because we're pushing on the revenue side of things. But Mark, to your point, if we get that member back in the center and we've got them on board with care and taking ownership of their health, well, the cost side of things can be driven down too through different healthy activities and lifestyle changes, and actually being a part of their own care plan, as opposed to, all right, we've documented the condition, now they're on their own. We can drive down the cost side of things and free up some of that capital as well to do these investments that we're talking about. And it doesn't have to be then just top line revenue growth and kind of the exploding equation that becomes healthcare as a percentage of GDP. We can start to move that further down and bring out savings in other ways.
I think one important piece, and Mark, you were mentioning about the journey for your parents and others, we're in the system. We should and probably all have a much greater understanding of the workings of the what's, the whys, the hows. But when we get to serving our members and the patients of those providers, that gets lost. This is a very foreign concept to them, other than I go to the doctor, I get seen, I go pick up my script, I go home, that's it. And when things don't work, it's very confusing. And so though we try to say we want to put that member, that patient centric to all of what we're trying to do, we've got to realize that it's a language that we speak and it's the processes. And if that's creating havoc for the members, I'm not sure how best to get a better understanding if the people making the decisions already have a preconceived notion of how things work, because we help to design it at any level within our organizations. So I'm not sure how best to get that convoluted confusion and clear up some of that muddiness that happens in our processes so that we can work more effectively with all these players that you've talked about in service to the patient, to the member.
I mean, that was something that culturally, I think it has to start at the top of an organization. And I know for me, I was relentless about keeping it personal, making it personal, getting employees of the company to tell their own stories of their own journeys or the journeys of their family and how they experienced it as a caregiver for a family member or in their own, and keep that in front of them. I mean, I remember it started in our customer service. It's like, when that person's on the line, they are not a transaction. What if you need to imagine and serve as if that person is your own brother, sister, mother, father on the other end of that phone. And you have to advocate for them within this often complex system, the way you would for your own family. And and then it just, we had to get that throughout the company so that people kept it real. It's so easy to make the process the thing that's real, or the rule or the policy, and forget that no, what keeps it real is the journey of the patient. And I think that's one of the things that, that's how we can get off track. Nate, you talked about how we've kind of gotten off track in terms of risk adjustment. I think it's because it becomes about process and dollars and cents, and we get away from keeping it real. And that's a failure of leadership, in my view. That's our job as leaders.
So this has been
easy. I don't want to oversimplify it, but it is our job.
Yeah, no, absolutely. And I think for all of us, we have to think about it, as leaders within what we do. I just want to summarize as a final thought, here at Innovaccer, we've had these principles for the company, for culture, transparency, it's all about data, right? But we got to be transparent to collaborate, teamwork, which is the basis of collaboration, right? We got to work together to serve the member, and then empathy. And I think empathy really kind of goes underneath a lot of what we've been discussing to really provide the kind of leadership you described. I think we all have family members. We're all been patients and navigated the system. So if we can think about that, be empathetic for what our members go through, be empathetic for what our providers are dealing with, and giving them the right tools so they can be successful and we can all collaborate. I think that's really captures a lot of what you've all been describing. So with that, I want to thank each of you for participating as members. I want to thank the audience for attending today for the webinar and our guests. And I think as a final thought, let's not see any headlines next year. And let's think about Mark's presidency candidate, that he's going to solve the world's problem now that he's stepped down from Gambia. So anyway, seriously, in all serious, Charlie, Nate, Mark, thank you so much. And this concludes today's webinar. Appreciate it all.
Thank you, everyone.
Thank you.
Thank you.